Welcome to the Six Hats podcast, where I, Dr. Shami, a lifestyle and nutritional medicine family doctor, will talk about how women strive to find balance each day by juggling their six roles, being a woman, mother, daughter, partner, business owner, and professional. Hello, everyone. Welcome back to the Six Hats podcast. And this conversation I've been so excited to have with Dr. Gina Claxton, a wonderful clinical psychologist based in Melbourne. Now, we're going to sort of dive into psychology with a slightly different angle. It's the neuroscience, psychoeducation. I just can't wait. So welcome, Gina.
Hello, Shami. Thank you for having me.
Gina, you're such an experienced psychologist. Am I correct in saying, over 20 years of experience now?
About 2 decades, yeah.
Amazing. But you're different. And this is what we're going to go into with the PhD that you did. You're a clinical psychologist. What did you find that was happening in the world of psychology that you felt could be different? And what steps did you take?
Well, as clinical psychologists, we're all trained under cognitive behaviour therapy, CBT. That's what we're all known for because of the pre and the post testing that you can do. And that, when I say testing, I mean like standardised questionnaire, and you can their outcome measures after treatment. And I found that when I was doing my doctoral thesis on early trauma, there was a big resurgence of John Bowlby's work on attachment theory. He's the big attachment guy, which after CBT came into faux after behaviourism, attachment sort of took a back seat. Now we know with attachment, it is all really the primary basis of trauma, because attachment trauma is the biggest trauma in our neuroscience world. When I say trauma, Shami, I mean a state of overwhelm. I mean a state that things are happening. It doesn't have to be a big major event like a tsunami, but it can be a birth of a sibling, for instance, and then your place changes within the family. And if the brain cannot process overwhelm, then we have these processes in place where painful information is compartmentalized. But that doesn't go away. That's held in your emotional memory, which is held in your unconscious mind, and it plays out in your dream cycle. That's your emotional life. So learning all of this, we can see that there are trauma roadmaps in the brain that actually, with the resurgence of neuroscience, we can tell that cognitive work cannot be processed because it can't be top down if your brain, your hippocampus, your prefrontal cortex, your thinking brain is flooded with adrenaline. And then simultaneously, cortisol is flooded into the gut, and serotonin, and changing all your sleep-wake cycles. And so we see that this is a whole body-based response. And we can't just work by changing thought process. And besides which, we can't just change deep-seated, deeply entrenched core beliefs that have occurred because you've had a dismissive parent or an abusive parent, and you've interpreted those interactions and those experiences deep within your neural clusters in your brain. They don't get upgraded because the hippocampus can't function. It shrinks, actually. We know that it shrinks through PET scanning. So CBT, I found in my work, while there's a place, because we want to do a digging down process and find out what the main core beliefs are that are getting activated, we relive them, we reactivate them with everyday triggers, but we can't change them by working cognitively top down. It has to be bottom up because, as I just explained, trauma and deeply unprocessed emotional information and experiences held in the emotional memory are held in your neural clusters. And so it's body-based therapy that I do, bottom up, right? So you go into your body to reconnect with those unprocessed emotions, and the body remembers. The trauma's held in the cellular level in the body. So we do a combination of body-based therapy and then brain-based therapy. And that's why I've grown with my patients, and I've learnt more and more on how neuroscience coupled with emotion-focused therapy is how we make brain change. We rewire the brain, we rewire those pathways so that it doesn't default straight to anxious brain, depressed brain. Because that's not the person's brain. This is all reactive. These are all responses. These are all behaviours. These are all emotional reactions and responses. So we can see beyond that. It's not the person. person's still there, but the anxious brain or the depressed brain dominates.
Absolutely amazing. And I absolutely love working with you. I know many of my patients, do see you just because of that. It is about rewiring, looking at the neuroscience. So how about we take a few steps back? I would love for you to explain what happens to the mind and body when you are in the fight or flight response, in that anxious state or in that stress response of overwhelm.
Sure. So I'll give you a bit of psychoeducation, shall I?
Awesome.
Yeah. So look, I'll start with the basics that we're all pre-wired back to caveman day to have an anxiety response. Remember, anxiety is a survival response. It's how the nervous system protects us. It's our stress response system. So today we're not fighting off tigers, but we are, say, triggered by an uncomfortable situation at work, or to give you an everyday example, if we were walking and a dog barks at us, we're going to get an immediate reflex response of a startle response. The brain giving you an adrenaline release, an arousal response where your blood's pumping fast, your lungs expand to give you oxygen because you have to make a quick involuntary move, say if there was a physical danger like an aggressive dog, to get out of the way. And then as we peak from that adrenaline response into an arousal response, that eventually we come back down to a baseline and that the anxiety cycle's complete. But what happens here is the nervous system can become faulty. The way in which the nervous system responds and interprets information can become faulty because you stay in an extended state of fight or flight. So can I break it down for you? There's basically 3 states of the nervous system. And when I'm saying the nervous system, Shami, I'm talking about the autonomic nervous system. So not the central nervous system, your brain and spinal cord and your ability to think and those cognitive processes. I'm talking about the autonomic nervous system is the brain stem down, right? So that's subcortical, below the brain. So if it's below the brain, it's not in our conscious awareness. So it cannot be cerebral. It's not cognitive. It's not intellectual. It's in the body. The body is responding. The nervous system is responding. So this is our neurology, our biology, because then we have a heap of physiological responses that go along with that. So if I give you the basics, there's 3 states of the nervous system. It either is safe, where it's healthy, it's calm, it's balanced. We have growth, we have restoration. If there's any sort of ruptures or conflict, we know how to restore because we're born into this system of safety and connection. And in that system, we have our social engagement system on. So if we're connected, we can connect to other people, right? So we have, and this is where I teach my patients as well about emotional self-regulation and co-regulation with another person whom they feel safe with. And co-regulation is primary. It is one of the biological imperatives. As children, we need to learn to co-regulate just as much as we need to have food and water, right? So that's where attachment comes in. That's why attachment is a big trigger point. So in therapy, you have to come back to that sense of safety. And sometimes when hasn't been secure attachment because of trauma, we have to rework attachment, and we learn to attach again in therapy with a safe therapeutic relationship. And then I help people do it in their personal life. So the sense of safety, which is the state of the nervous system we want to be in. And then we have a fearful state, which is fight or flight. And then we have a state of danger. And I don't mean physical danger, like I gave the example of the barking dog. I mean a state of danger where things seem so overwhelming and overbearing that we need to retreat and shut down. And I give a visual of a turtle. So a turtle, it bobs its head up to sort of check, oh, it's not safe. And it bobs its head back down and stays in its shell because that's its safe place. So it's either, so the nervous system, 3 states, it's either safe, it's fearful, or it's dangerous. And if it's dangerous, I need to retreat. And these states, the technical terms for this, which you would know, Shami, the sympathetic nervous system and the parasympathetic nervous system. Those are the 2 nervous systems which make up the autonomic nervous system. And in early evolution, very early in the prehistoric days, when we had prehistoric animals, the first fight of survival was the parasympathetic nervous system. This is the oldest nervous system that we knew about. And that parasympathetic nervous system is made up of the vagus nerve, And the vagus nerve, as you know, Shami, is the biggest cranial nerve that comes from the brain, goes into your face, heart, lungs, ends in your gut. And so that's why we have the gut-brain, the brain-gut axis. And as you'll know, so many of our patients have a lot of gut issues, irritable bowel, and all those different gut symptoms, which are very much related to stress and anxiety. And we treat them, and that's why you and I work so well together, because we work in an integrative way where we can both contribute to their overall health mentally and physically. So the parasympathetic is broken up by the vagus nerve into two branches. The ventral vagus, which is when the vagus can go and do its job and come back to a system of safety, the first one that I spoke about, or it goes into that dorsal vagus, which is the shutdown state. Because if you've been stressed and anxious for a prolonged and protracted amount of time, it's too big a jump to go from a heightened state of fight or flight back down to a baseline of safety, right? So if I explain the states a bit more, is that okay?
Absolutely. I'm loving this, by the way, Gina. This is...
So the very first state of the nervous system that we knew about was the parasympathetic dorsal vagus. This is a state of immobilization, that state of collapse and a state of paralysis where so early in the day, I started to say about the prehistoric animals, when they were in the heart of danger, so they'd see a predator in the foreground, what they would do as a survival instinct, Shami, was to collapse and feign death. And then the predator would think they were dead, and they'd go to find their next prey. This is a system in which we adapt to protect ourselves from what we perceive as a danger in our environment. And we do this through the act of disappearing. And it's a way in which we conserve all our energy and our internal resources. In this state, I remember my patients to remember D for dorsal, because all the Ds exist in this state. D for disappearing, D for depression. Depression exists in this state. D for dissociation. Dissociation meaning that checking out of when you're present physically, but your mind is protecting you by not being there. And this is what people use in trauma responses as a way in which we can contain ourselves and compartmentalize things that are too overwhelming to process. So disappearing, depression, dissociation, it's a dumbing down state of the nervous system. But most importantly, Shami, it's a state of dysfunction. It's a dysfunctional state and a dysregulation of the nervous system. So the D really for dorsal stands for dysregulation. If we stay in this state for too long, it is faulty, because now we cannot recognize when there are safety cues, even when it's safe. So in therapy, I create a safe space, but it might take time for us to connect and develop that deep therapeutic trusting relationship for that turtle to come out of bob its head out and let me into its shell. Well, I say let me into your bubble, really, to be able to expose and be vulnerable to those emotional states. So we may not if we stay in that state, we cannot see safety. Likewise, we may not see risks when actually it's a dangerous situation. Right? When we see that risk-taking behaviour of people who don't, actually that's when we have to really look at depression and suicidality then, because risk-taking and not seeing the danger cues is a very, very dangerous state to be in, because that nervous system is dysregulated and we need to learn to regulate it again.
Yeah, can I ask a question about this state? It's fascinating because, from what I understand, I know about the sympathetic, I know about the parasympathetic. But what I really learned here is about this dorsal state.
Yes.
And it's mind-blowing, because I'm just thinking of so many scenarios where people could be in that state. And could this also happen if someone's got post-trauma but in chronic fatigue for, I'm talking about 15, 20 years? Is that a possibility?
That's a dorsal state, hands down. It's a dorsal state. And that's a state, and the brain, and also the brain's wired into that sickness state. Or, like it's not to say that they're not sick and not unwell. They definitely are. But the brain pathways are also wired, and they'll just keep triggering neuron to neuron of the sickness pathway. But that's a definite dorsal state of dysregulated nervous system, and probably not recognised as such. But because I can tell you that lots of our patients won't know they're in that state, because they go about their day-to-day, Shami. They will go to work, some of them. They run their households, they run their families, they have long-term relationships, they have responsibilities. Guess what? They're in autopilot, because in a dorsal state, your emotional brain is shut down and your social engagement system is shut down. So if you're disconnected from yourself, is that another D word? Disconnected from yourself, you cannot connect to other people. You're disconnected from other people. So in autopilot, what we have here is a state of psychological numbing. And in a numbing state, we use what's at our fingertips to soothe, right? Without knowing. It's not necessarily conscious. So people use what's at their fingertips to self-soothe. And a lot of those things actually are quite harmful or dysfunctional. They're unhealthy coping strategies like alcohol abuse, like drug taking, like gambling, like porn and sex addiction. A lot of people use food to numb and have a very unhealthy up and down relationship with food and diet. A lot of people use sleep when they've got, very depressed. People might use shopping. And currently, actually, the latest things are Netflix binging and phone surfing. So when you see people, sitting in a doctor's surgery waiting to go in, they might be nervous, but they're surfing on their phones. And that's their state of being in that shutdown state and not even realizing. And as you know, all of these things are addictive. Work can also be work, exercise, anything that's excessive and takes people out of their bodies into an escape state is that parasympathetic nervous system, dorsal vagus state.
That's incredible, because I was actually going to ask about alcohol and the addictive nature. And so it really makes sense why sometimes people find it hard to come out of alcohol addiction, because that's all the help that's out there is just focusing on the behavior.
Yes.
And really going into the neuroscience of the brain and the dorsal vagal state of it's used to soothe them, because that's how they're coping with life.
That's exactly right. And what's happened then is once it becomes problematic, as in alcohol or drug taking, then that forms its own problem, and it's problematic in and of itself. So then problems spill off from that. Right, because it's their go-to, and they do get that warm, fuzzy GABA release when they take drugs or alcohol, and it does cause that decompression and that de-stressor in the body. I never start when I've got so many patients that are self-soothing, self-medicating, we call it also. I never start there, Shami. I always start with the nervous system, learn to regulate that nervous system when we've got those skills and we know how to manage our own anxiety. Then we can learn emotional skills, and that's key too. Learning to regulate emotions and not dysregulate. Instead of being dysregulated, then we learn how to work through triggers and emotional states, and that replaces alcohol. But it takes a long time in therapy to do that, because what happens is people will go from the dorsal state up into the next state of the fight or flight. Did you want to ask me something, or shall I go into the next state?
It's perfect to go into the next state. Absolutely. Yeah.
So I spoke about the dorsal state as the first as the base state. So if I had a whiteboard here, if I'm face to face, it's a hierarchy, right? And it's a ladder. So dorsal is at the bottom of that ladder. The middle rung of the ladder is called the sympathetic nervous system, the sympathetic arousal. Now, this is a system of mobilization. So as we've evolved and we've got the development of the cortex, we have now a system of arousal which moves us. Okay, that's what fight or flight is. So if I use the wild as our example, if we had a deer that sees a predator in the foreground, it becomes a stunned deer. You know that saying, a stunned deer in the headlights. That deer is in a fight, flight, freeze state. So in a freeze state, it's not frozen like dorsal. It's a state of deciding, is it going to fight or flight? So in the freeze state, that's when I said earlier, the blood's the heart's beating fast to give you like the blood flow is pumping, the oxygen's pumping out to the limbs, because that deer has to quickly mobilize and either fight the predator or run for the hills. And it's again an adaptive and protective response, but this time through action, not inaction. So it's an aggressive attack or it's an active escape. Now, people, again, don't know they're in fight or flight, which coming out of our lockdown years, when everybody was probably in fight or flight, there's been an extension of that, and the brain has stayed for a lot of people in a heightened state of arousal. So people are triggered very, very easily. So if you get drawn into a difficult conversation, a bully at work, or somebody who overpowers or talks over you, your heart can start beating fast because the arousal is there. Am I going to get drawn into an argument and a drama and a stress? So did you catch when in everyday occurrences, we get triggered? So if somebody's talks over us or dismisses us or is a bit aggressive in their interactions with us, very quickly, nervous system thinks that we're under threat, and it protects us by releasing adrenaline. And this is what the nervous system does. It tries to protect us by giving us the arousal. We're either going to get drawn into the argument, anger, conflict, that's the fight response, or we're going to actively choose to escape, leave the situation, avoid, procrastinate, and that's our flight response. So we're constantly in a fight, flight, freeze state. And again, people may not realize that just because we're not in the old stereotype of blowing into a paper bag because we were, having a panic attack. We don't need to be in a state of hyper arousal to be in a fight or flight state. And our patients, Shami, we would see are mostly in either sympathetic arousal, fight, flight, freeze, or they're in dorsal vagus, depressed and
shut down.
Under the radar, shut down, very shut down and disconnected emotionally. So they're the two states we see. But the top state, which I think I started to talk about earlier in the piece, is when the parasympathetic nervous system can do its job and downregulate the adrenaline and come down to a baseline. And then the vagus nerve is now in its place called the ventral vagus. And that's that state that we want to get to. And it's a system of safety, connection. As I said, this is where we can process. So we don't have to be in a Zen state. It's normal life situations and interactions. But in this state, we can feel safe to process anger, to process hurt, to resolve conflict. And these are the states when our patients who have been anxious and depressed for years and years and years on end, we don't know how to get to that state anymore. And when I ask people to get into that state, they can't remember the last time. So that's the top state. So we have safe, which is ventral vagus. We have fight or flight, which is sympathetic arousal. And then we have dorsal vagus, which is shut down or retreat state. So these states, intermittent states, Shami, and in my sessions, I put people into each of these states, and then we record their physiological responses, and we record the imagery that they use in those states. And we just train people to move in and out of those states and to understand that this is not your personality. These are not fixed personality traits that are permanent states. This is your biology and your neurology and your physiology. So that means we're empowering you to know what your nervous system is receiving, how it's responding, what state you're in, and how we need to move in and out of those states.
That's amazing. I love that. And it's funny you should say that because patients do understand that's their narrative now, that's their vocab of I'm in the dorsal vagus, I'm in the sympathetic, and it's amazing. It's so empowering. But I'd love to go on to actually explore, how do people know that they're in different states?
Yeah, so what we would do, we record when we go into the states and we think about a situation in which we felt very removed and shut down and dark. And then in which we felt very depressed or very we didn't want to respond to text, or we didn't want to accept invitations to social events. And we tune in. This is what emotional regulation is. We sit, we ground ourselves by placing our feet on the floor, and we go into our bodies and we ask ourselves, where in my body is this landing? And this is really tricky for people because in anxiety, we're in our heads and we're out of our body. And we don't know, and people really don't know. But if we stop and we tune in and we help them tune in, they will be able to tell you what physiological states they're experiencing in that moment. So for dorsal, it'll be a very heavy feeling like lead pulling you down into your body. There'll be fatigue, like exhaustion. There'll be lack of motivation. You can't get out of bed or can't get off the couch. You have no inclination for wanting to do so, right? It's that feeling. When it's sympathetic arousal, it's that whole gamut of anxiety, physiological responses of anxieties, such as accelerated heart rate. You might hold your breath, or you're holding down your breath, or your breathing is accelerated and shallow. Your mouth is dry. Your tummy feels churning, butterflies, or your tummy just feels that sinking feeling, that dropping feeling. You might be trembling, shaking. You can't hold on to your thoughts because they're looping. And there's a reason that they're looping too, which I can tell you in a sec. But so can't hold on to thoughts, or you go blank. So all of these are sympathetic states of fight or flight. And when you're in a system of ventral, a system of safety, there's a lightness in the chest. There's a real freeing up, and people firstly just know not feeling tense. There's not that tightness in the muscles, and it's a warmth, a feeling of warmth and glow, and just, that overall kind of like lightness that you feel in your body. And so we learn to emotionally regulate by going into those states as they're occurring just for a couple of seconds, because we want circuit breakers from that constant sort of worrying cycle of fight or flight. And in those circuit breakers, if we allow ourselves to sit, which is hard because we want to be able to move in an anxious state, we want to do two things. One, increase our ability to tolerate distress. So distress tolerance is really good to learn, a skill to learn. And the other thing is we want to learn to our ability to tolerate discomfort anxiety. The discomfort anxiety is because the arousal makes us want to move and be agitated and fidgety and pace and all of that. So we learn concrete and constructive strategies that we can use in that moment. They don't have to be the biggest skill here is to give yourself choices. In a fight or flight response, we feel trapped like a caged bird, and we can't move out of it. So always give yourself options and choices. To have control over an environment that you don't feel you have control over is one of the biggest techniques to reduce anxiety. Because it's called controlled incongruence. It doesn't match the environment. So when you take control, and that control could be a couple of things, like I'm going to send a text to say, can't talk today, talk tomorrow, or I'm going to go and lie down because I feel unwell, or I'm going to go outside and just ground myself and just collect my thoughts, or I'm going to reach out to someone in my tribe and co-regulate. See, small choices like that help people move out of fight or flight and feel safe again, even if it's just temporarily. I'm just interested in a few seconds to break circuits.
That's amazing. Can we go back to what you were saying about looping?
Yes. So one of the biggest things in fight or flight is that the limbic system, which is our stress response system, as you know, is in the right temporal lobe. And in that right temporal lobe, we have a brain structure called the amygdala. And the amygdala is like a smoke in an anxiety cycle. It's like a smoke detector which needs its battery changing. So it goes off, it's cranked up so high. And when it's cranked up so high, it cannot regulate itself. So neurochemicals like serotonin and cortical blood flow, cortical as in cortex, can't get pushed forward to your prefrontal cortex, which is your smart brain, your thinking brain.
Which is the front, just for those listeners who don't know, the frontal cortex is at the front of the brain. Yeah,
front of the brain. And that there's another brain structure called the hippocampus, which is there. And that is our structure that takes in context and information. And if we looked at a PET scan, that is shrunk.
Wow.
When the anxiety when a cycle and the looping is flooding your brain with adrenaline, and your gut is flooding with cortisol. So neural activity in a PET scan will show that hippocampus is shrunk. And if it's shrunk, that's what I was saying at the start of this session, Shami. That's why cognitive processes cannot work to their capacity, because if the hippocampus is shrunk and you can't take in information, I can be telling you things until you're blue in the face, but cognitively you can't take in information. So that means your concentration span is poor. Your attention span is poor. Your short-term memory is shot. People who are in that state can't focus. They can't read even one sentence. They sit on their screen and they're going over the same thing over and over again. They're forgetful. They're indecisive. They think that these are personality traits, but these are actually anxiety symptoms, cognitive symptoms of that anxiety cycle when the amygdala is absolutely dysregulated. So it's on fast track. That's why you can't think. So when we emotionally regulate, when we learn to regulate, when we regulate the nervous system, the amygdala comes back down onto slow track, right? Slows down. Another part of the brain, the insula, takes prominence, and then that takes you into your body, into your felt sense, and to be able to access our emotional states. And then the prefrontal cortex, which has been offline during trauma states and during anxiety states, comes back online, and it goes on fast track. And if we can think clearly and rationally again, that's when we can make those choices that I spoke about and make those decisions and have options to move out of the arousal state.
That is phenomenal, Gina, because I'm thinking back going, many, in today's society, people want quick fixes.
Yeah.
And they go, right, this is how I'm feeling. I want to feel better. And the quick fixes, unfortunately, when you do go and see a doctor, there is such a quick fix. And it could be offering medication. And of course, as a functional practitioner, it is looking much deeper, and you have to look at all the other lifestyle factors. But what you've really, really highlighted, these neural pathways have been set in for years for some people.
Yeah.
And that takes time. That takes time to rewire if you don't have the right practitioner in front of you.
Right. So I would start, as we know, most of our patients have got a trauma history, and I think we all do just in some capacity. But I don't go straight to get the trauma history, because the trauma roadmap is there. And what we need to do, if we just go straight into hearing the trauma story, that's really about us, the practitioner, and our curiosity. It doesn't matter so much initially, because what matters is that the brain is still being impacted as though the trauma was happening today and not 20, 30, 40 years ago. So we have to regulate the nervous system. We start there with neuroscience. It's about the neuroscience of mental health, the neuroscience of attachment, neuroscience of trauma, depression, anxiety. We learn to, as I keep saying, down-regulate those physiological arousal states, fight or flight, coming out of dorsal to feel safe enough. And then slowly I would do trauma work, not necessarily to get the whole trauma history, as I said, but just to integrate parts of their self. This is parts integration work now in emotion-focused therapy, that integrate those childhood wounds, those unprocessed traumatic experiences into the adult functioning brain. Right. So we've got parts of ourselves where we've got the responsible adult part, we've got responsible employers, we're parents, we're daughters, we're sisters, we're brothers, whatever. And these parts of ourselves are functioning mostly. But so we need to just integrate those wounds into that part of those parts of ourselves as well. And that's when it takes time. But you've got to do the nervous system first. You've got to learn emotional regulation first. And then we do trauma work and grief and loss work a lot of that time. It's not about blaming anybody or reliving your history or your childhood, but it's about whatever you feel, you think, having that safe space, and it's done in a way that's nurturing and nourishing and supportive and validating, non-critical, non-judgmental. And that's how we rewire the brain. Because it's that sense of safety that you're getting in therapy, in the therapeutic connection and the therapeutic space and the emotional space that allows the brain and the nervous system to process the trauma. And there'll be a heap of other therapeutic interventions that we use, grounding techniques, and I'm always learning and updating all the current cutting edge techniques that are coming out in neuroscience. And then working with you, we haven't touched on this either, is about metabolic health. So if we've got dysregulation of the nervous system, then we've got dysregulation of the metabolic health system. And that's why we know about diet and genes and all the other factors that contribute into that very integrative whole health approach that you and I work in.
That's amazing. Absolutely amazing. And great, you're a massive fan of that holistic approach. How often do patients sort of challenge that? Because, it's a lot of work creating behavioral change when it comes to sleep hygiene and movement and looking at diet. I'm going to ask a question. Is it too much at the beginning of their journey to look at everything, just from how you've explained? Or it's a necessity. Do you take it slowly, one step at a time?
Yeah, of course.
Yeah.
So I give a framework because then it helps people. They love to hear the psychoeducation. They love to hear, oh my God, I'm not crazy. This really gives me context. Like I'm reading your mind. And it's not because I'm reading their mind, literally. It's because it's so familiar to me, because it's so commonplace that people experience this in the same way. You know, it's all the same thought trains, all the same behaviors and responses. So I just start with giving the framework. And then I say, don't worry about taking it all in straight away, because we go over it and we go over it and over it and over it. And then I just orient them back to those key points of, as I said, the dorsal, the ventral and all of that. But slowly, and I work at their pace. It's got to be like a teamwork approach. It's got to be collaborative. And I always edit. And I can tell if people it's too much in the session. You can see in their eyes they've dissociated and checked out. And that's only because an internal implicit memory has occurred. And so it's too much to absorb. It's a trauma response. So then I just bring that to their attention, and we might just do some grounding and some restructuring and then go from there. So we both work together, but I very rarely have anyone that finds that too overwhelming. They actually find it quite a relief to know that there's a pathway out, Shami.
Makes sense.
That I'm giving direction and like working in that staged approach, neuroscience, CBT just minimally, and then emotion-focused therapy to do the trauma work.
Amazing.
And each person is very different and each session is very different. And so I think that's how we work together.
That's amazing. And I think this is also a good reminder to say, let's think about also sleep hygiene, nutrition, key nutrients. What are you eating? Is it protein-rich food, nutrient-dense food, as well as working on the neuroscience, because everything contributes. People do feel better. Like, for example, key nutrients that I talk about, magnesium, vitamin D, the Bs, especially B12, 6 and 9, omega-3s, key nutrients for mental health that often are not talked about. Even iron. Iron is so key for all the happy chemical pathways. And that's why we work so well together. I work on that element and metabolic health and sugar and how it's so inflammatory for the brain. And a really good low carb, high protein diet is phenomenal for mental health. And that also is regulation, because you feel better, you've got more energy. And then that's why the holistic way is the way forward.
Yeah, and that's become like my latest passion in the last 2 years, because you can't separate them out. You cannot do mental health without doing metabolic health. They both feed into each other. And I just don't think you can work standalone. Like I've worked with people with neuroscience, and you get them to a certain point, but then their diet is still causing them fatigue and depression and anxiety. And when they learn about all of this, and we work together like that, and that's why I am developing that online program to incorporate them all. I just don't think you can separate them out. We think it's resistance, that people aren't doing it, but it's actually people still in the dorsal state, and they just don't know how to get out of it yet. So
that's amazing, Gina. And we will share all the links of how people can find you in the show notes. Thank you so much, Gina. Remember that this is general advice only. Please see your healthcare professional for more information. So what's your take-home message today? Remember, it's all about progress and not perfection. And are you suffering from stress? Visit the Usawa Learning Hub on usawa.com.au for more resources on how to de-stress, re-energize, and reclaim your health. Enjoy the journey.